Okay, let's start. Let me introduce today's speaker first. Today's speaker is Bowen Li. Bowen Li was a senior research scientist at PAII Inc. and now is a PhD candidate at Johns Hopkins University in Dr. Alan Yu's lab. During his time at PAII, he did research work with Dr. Adam Harrison, Dr. Korean, and Dr. Lelu, focusing on developing deep learning algorithms for chronic liver diseases. His paper, Learning from Subjective Rating Using Auto-Decoded Deep Latent Embeddings, won the Student Travel Award in MICCAI 2021. He won the Young Investigator Award in Asian Federation of Societies of Ultrasound in Medicine and Biology 2021 conference for the clinical impact of this work, which is a prestigious award from the largest ultrasound clinical society. Bowen, please start.
Okay, thanks so much for Dr. Zhao's introduction, and welcome everyone to our today's discussion, Diagnosing Chronic Liver Disease via Ultrasound with Deep Learning Methods. As introduced, I'm Bowen Li, and previously I worked in PAII Inc. Bethesda Lab as a senior research scientist. Now I'm a PhD candidate at Johns Hopkins University in Dr. Alan Yu's lab. All topics discussed today were investigated during my employment in PAII Inc. In this talk, clinically, we will cover two diseases, liver steatosis, which is also known as the fatty liver disease. Liver steatosis happens when our liver is filled with fat cells. So the gold standard to diagnose liver steatosis is pathology biopsy, so that pathologists can count the ratio of fatty cells in our liver. Another disease that we're going to cover today is liver fibrosis. And that happens when scar tissues fill out our liver. The late stage of liver fibrosis is called cirrhosis, and the diagnosis gold standard is also biopsy. However, most commonly for these two diseases, the screening method are ultrasound in annual physical exams. So we want to help hepatologists to read ultrasound images with more confidence. To diagnose, we introduced three deep learning-based methods, where we use the first two methods to diagnose liver steatosis and the last method to diagnose liver fibrosis. All methods discussed today could be found in our published research papers. I feel so honored to work in PAII Inc. because I can collaborate with top scientists and clinicians. In this liver ultrasound project, I worked together with Dr. Yan, Dr. Lu, and Dr. Harrison to establish several algorithms and finally deliver a set of software to our clinical collaborators. Dr. Dar-In Tai from Chang Gung Memorial Hospital is our clinical champion. Dr. Tai collected data and set up the clinical trials for this study. And he is also the first who adopted our algorithm into the clinical diagnosis routine. Later, we also worked together with Dr. Ren from Shanghai Ruijin Hospital to test our algorithm. So first, we will introduce our clinical journal work, which serves as our baseline today. In this work, we predict liver steatosis by ResNet with clinical view grouping. This work is accepted by the World Journal of Gastroenterology. The clinical abstract was also presented in 2021 conference of Asian Federation of Societies for Ultrasound in Medicine and Biology and won the Young Investigator Award. Conventional ultrasound is a common screening modality for chronic liver diseases, including liver steatosis and fibrosis. So liver steatosis patients, when he's diagnosed by the ultrasound first screen, he or she will be scanned several times within the 3 to 12 months treatment. So it's a good practice if we can diagnose the liver steatosis progress within this time period and establish a longitudinal study for this patient. Doctors will give semi-quantitative diagnosis for steatosis. And the levels here we are talking about are healthy, mild, moderate, and severe respectively. So the thing we are trying to predict here is that whether our algorithm can also do this full-class classification. And as we know, it's a ordinal regression. So all these 4 levels have a order. Hepatologists does not really affect too much in the image reading process of ultrasound images. So that's a good advantage. And the best thing here is that ultrasound is a non-invasive modality. However, there are some drawbacks. So reading ultrasound images is very subjective. It depends heavily on doctors' expertise and experience, which leads to low inter-reader and intra-reader consistency. So that's our goal here. We want to lower this subjectivity and then help doctors to get more confidence during the whole diagnosis procedure. Pathological biopsy is recognized as the gold standard for diagnosis. However, this means an invasive surgery, so we do not think that all patients need to go through that. So that's something we want to get rid of. Another alternative non-invasive imaging modality is called fibroscan. It's also an ultrasound-based modality, but its availability is quite low right now, and the sensitivity is can be affected based on the hepatitis conditions, and most of the time it's not covered in some health insurance plans. So this is the method that we want to do a comparison with. Compared with other medical imaging modalities, for example, CT or MRI, ultrasound is quite special. First, ultrasound is operated by sonographers, and each hospital might have a different acquisition protocol. So that means a randomness during the image acquisition process. So a good algorithm here should be able to deal with all the different combinations of scanners and imaging protocols and all these randomness. Second, we can see in this video and in this figure here that ultrasound images are pretty vague when we compare it with CT and MRI images. Finally, an ultrasound sequence includes multiple images. As we can see, the sonographer is getting a bunch of medical ultrasound images from different angles. So our algorithm should be able to select key frames. Sorry, so it should be select key frames in this sequence. To sum up, we want to build a clinical decision support system for ultrasound liver steatosis and steatosis diagnosis, which can learn from the diagnosis from the top hepatologists and provide objective and reliable liver steatosis scores with only conventional ultrasound images required. We want this system to classify patients into 4 stages of the steatosis, and it should be able to work with images from a variety of ultrasound scanners and acquisition protocols. We hope that it could help doctors to make reliable diagnosis. To train this deep learning network in the data preparation stage with retrospectively collected data from the PAII system directly and prospectively collected data from clinical trials, we set up the largest scale of liver ultrasound dataset compared with all articles we could find in literature review. In this dataset, we have more than 3,800 patients involved, and the ultrasound images are more than 200,000. We carefully split the data into groups to train and validate the algorithm. The last group I'm showing over here, which is called HPT, was blinded to us during the research stage and was only revealed to us when all parameters were fixed. So we hope that with this group of data splitted, our algorithm could be unbiased to all our research process. Because ultrasound images are a sequence of 2D images and hepatologists cannot get the panorama of the liver within only one image. So sonographers have to scan patients' abdomen from multiple angles. We followed the clinical guideline to filter ultrasound images acquired by sonographers into 6 viewpoints, which captures a different angle of the liver. In this figure, we have each viewpoint plotted, where the blue square indicates the position of the ultrasound probe. These viewpoints are then further grouped into 4 groups: left liver lobe, right liver lobe, liver kidney contrast, and subcostal. Each includes 4 to 8 images. We trained a deep learning-based view group classifier, which has 2 functions. First, it can filter out unqualified images, which means image with low quality or images do not belong to any of these viewpoints. Second, it can tell us the view group of image, which is used in the later aggregation step. Our dataset includes patients with different clinical background. In each data group, we have patients with hepatitis B and hepatitis C. So the algorithm could be trained to be robust to the existence of hepatitis. The distribution of steatosis is quite unbalanced because this is a retrospectively collected data from the PACS system. So we do not hope that each patient has a very severe liver steatosis. With that, to train the deep learning algorithm efficiently, we added weights, more weights to the severe stage, so to the cross atrophy loss, so that the severe steatosis can be detected. Luckily, Chang Gung Memorial Hospital has ultrasound scanners from many different manufacturers, each with different brands. During the training stage, our deep network has seen images from all kinds of configurations, so it could be robust to the domain gap of ultrasound scanners, and hopefully it could work with images from unforeseen ultrasound scanners. We also have another work that discuss the domain gap of ultrasound scanners by an intern and is published last year. In this slide, we show the complete workflow of our algorithm, which includes 2 steps: image-wise prediction step, and then aggregate them into study-wise prediction. Each ultrasound image is first screened by the viewpoint classifier. Only qualified images will be preprocessed, which removes the empty boundaries and split dual image into single images. Each single ultrasound image is then applied into a ResNet 18 backbone and 3 classification head. Outputs an ordinal regression result, which indicates the patient's liver steatosis result in greater or equal to mild, greater or equal to moderate, or equal to severe stage, respectively. After a score mapping procedure, we can calculate an image-wise score, where 0 means the patient is completely healthy, and 1 means the patient has a severe liver steatosis. Then we aggregate these image scores to calculate the study-wise prediction, which includes image information from each angle of the liver. We group images by their view group and calculate the average. View group scores are clinically meaningful to doctors because sometimes patients do not have images from maybe 1 or 2 view groups. So they need this view group score to help them to make diagnosis. And then a study-wise score could be calculated by averaging all results. And this is the prediction result we provide to doctors in most of the time. In this algorithm workflow, we didn't make too much innovation on the technical side, but it shows relatively good results and is robust to domain gaps. So it's adopted in our clinical journal paper. In this table, we show that our system could achieve repeatable measurements with a moderate number of images. We calculated the limits of agreement and compared it with clinical guidelines. On average, our algorithm only needs 3 images from 1 specific view group. So even if we only have images from 1 view group, and that is good enough for our algorithm. The performance is much better if all images from all view groups could be retrieved. As we can see in the last row of this table, the LOA is smaller and agreement is higher. Validation set and single blended clinical validation set. our system shows a high clinical grade performance. In this table, we compare our algorithm with FibroScan, and that is the alternative non-invasive diagnosing modality we discussed before. We can see that in all levels, our algorithm's performance is better than FibroScan, and statistical significance was achieved on most levels. With this table, we understand that our algorithm, which requires less images, works better than FibroScan. So to sum up, we successfully trained a deep learning network which could help hepatologists make detailed 4-stage liver steatosis diagnosis. This deep learning network is robust to the change of ultrasound scanners and acquisition protocols. Right now, it's being tested clinically in Chang Gung Memorial Hospital by Dr. Dar-In Tai's team. And that's our first project. With this project done, we asked ourselves a question. Is there something that could fundamentally affect the performance of our deep learning network? And we believe that the subjectivity during annotation stage could be one of the key factors. In this section, we are going to introduce a method to learn from subjective labels and harmonize it during the inference stage. We call it ADDLE, which is short for auto-decoded deep latent embeddings. Our research paper won the Student Travel Award in MICCAI 2021, and the clinical abstract was presented in RSNA 2021. It's common that labels in deep learning datasets are created by humans, so subjectivity is an important topic for researchers to investigate. We show 2 examples of subjective labels, both in a natural imaging dataset, Steatosis and a sentiment analysis dataset, Amazon Review. In our project, we use conventional ultrasound images where hepatologists assess patients' liver steatosis. And in this dataset, it's also the hepatologist who made this annotation. In medical datasets, labels are created by domain experts. It's very common that different clinicians have different annotations. For example, the different segmentation masks of this pathology image. So we can see that actually 6 pathologists have different annotations. And PACS system is a large data source for medical images, but still it's very noisy. So the problem we want to solve is that what if we have an effective method to model the annotator's subjectivity and minimize it during the inference stage? Researchers have done studies in this topic, for example, the EM algorithms, but they require multiple ratings for each image, which does not really fit in our dataset. In our dataset, each image only have 1 rating from 1 annotator. Another method includes the joint learning of subjective labels, which trains a standalone CNN backbone for each rater. However, this leads to a low computational efficiency and data efficiency because the network only sees a subset of data during training, and because each rater is trained with 1 standard backbone, it takes lots of time. On the other hand, the multi-height method trains a classification head for each rater. So theoretically, this creates a different hyperplane with the same backbone, which is not a very expressive model. The key problem that we are trying to solve, same with the previous work, is to assess patients' liver steatosis with conventional ultrasound images, which is considered as a subjective task for clinical diagnosis. As we are showing right now here, there are 3 ultrasound images, and to be frank, I also have a long experience with ultrasound images, and it's still hard for me to tell directly with instinct that which image indicates which stage of the liver steatosis. The diagnosis gold standard is the objective biopsy results, but biopsy, as discussed, is an invasive procedure. So we want to help clinicians to make more reliable forecast predictions with ultrasound images so that disease could be controlled in the early stage. In our data set, we have more cases with subjective labels than objective labels. The subjective training cohort is from the PAII system directly, which is an incredibly large amount of data, with more than 36,000 cases, and diagnoses are from 65 doctors. The gold standard cohorts are used to do validation and test. In our pilot study, as we are showing in the right bottom corner, we indeed observe different doctors' diagnoses have different correlation with the gold standard. So in sum, we want to put forward a deep neural network to learn from subjective labels and minimize the subjectivity during the inference stage, so that the system could help doctors make forecast diagnosis for liver steatosis. Our method is called auto-decoded deep latent embeddings, which is called ADDLE. In theory, for every input X, we should output the gold standard label Y. However, because of the limitation of data volume in reality during training, instead of predicting the final gold standard label directly, what we can do here is to learn to predict surrogate subjective label with reader ID as an extra input, and let the network learn the latent space of the subjectivity, and finally use an aggregation procedure to calculate the final outputs. We want to learn a latent embedding for each subjective reader, and the embedding can be inserted into the network to condition the output based on which reader is giving the diagnosis. To model the problem as to maximize the posterior probability of the latent variables, which can be decomposed into a prior on the latent embeddings and a likelihood on the subjective labels that we are observing. Note here, the likelihood is conditioned not only on the input image X, but is also conditioned on which reader's latent vector is being input into it. We model the likelihood using a deep neural network F with a set of parameter data. But unlike standard CNNs, our network accepts both image and the latent vector based on the corresponding reader. To maximize the posterior, we both minimize the data loss and regularize the minimization process based on the Gaussian prior. Importantly, the minimization is applied to the shared backbone of parameters and each reader's latent space. In this way, the network can learn reader's subjectivity. This is the place where auto-decoded method is happening, which creates a latent embedding for each reader in the latent space during the optimization process. Then let's see what's happening within each ADDLE block. Here we use a ResNet backbone as an example, but actually it can be plugged into most common CNN backbones. First, for each reader, an embedding layer translates it into a vector. After feeding it into a fully connected layer, we can get the latent vector. We need to resize and replicate the vector into a suitable size so that it can be added to the feature map before the batch normalization layer in a res block. Because this simple design philosophy, ADDLE can be easily integrated into a ResNet in all places or full level of res blocks. In our work, based on the performance on the training set, we chose to insert ADDLE into the second and third res blocks. During inference, we can emulate the subjectivity of each reader. Based on the availability of data, we have two options. If there's no extra data available, we can simply aggregate with the mean of results from all readers. Or if we can access extra data for curation, we can calculate each reader's performance as we are showing in this figure. and only aggregate results from the top virtual raters. In our work, we aggregate the top 5 doctors. Let's see the performance of ADDLE. In this table, we care about partial AUC, where false positive rate is smaller or equal to 30%, because only operating points in this region is clinically useful. First, we outperformed the baseline method, the vanilla ResNet 18 trained with subjective labels. So it's important to model the subjectivity during training. On the second row, our method even outperformed the model trained with a small number of objective labels. And that means that if we have more data to train and more data to see during the training stage, it's always good for our algorithms. For the joint learning of subjective labels, noted as JLSL here, which trains a separate backbone for each rater, it outperformed the vanilla baseline, but it's extremely costly. ADDLE is computationally efficient and practical. The multi-head method is the strongest competitor. We can see that our model performs better in most levels, and for the equal to severe level, our performance is still much better. Because our model calculates the latent space of raters, we can effectively analyze this latent space. For example, we can do a PCA on the collection of latent vectors. If we change the lambda during the this analysis, we can see that the change of performance. And this is an interesting part of this work, which leads to more future research, is that how can we meaningfully combine the virtual rater that we learned during the training stage and apply it in the inference stage. So some take-home points for our paper are, first, ADDLE is a practical method for clinical data, which learns subjective labels and calculates the latent space. It can effectively improve the final performance by minimizing the subjectivity during the inference stage. And that's all for liver steatosis learning. Right now, let's discuss a more difficult problem, is how to diagnose liver fibrosis with ultrasound images. Our pilot study shows that even top hepatologists have a lower agreement compared with the gold standard biopsy when they try to diagnose fibrosis with only ultrasound images. We put forward a group of methods here, including global hetero-image fusion and view-specific parameterization. Our research paper was published in MICCAI 2020, and the clinical abstract was presented in RSNA 2020. In this paper, we want to solve a multi-instance learning problem. Given a group of patient liver ultrasound images, how can we make use of deep neural networks to assess patients' liver fibrosis situation? To be specific, we want to predict doctors' ultrasound diagnosis. As previously discussed, ultrasound is the first-line screening modality for early detection of liver fibrosis and cancer. However, the drawback is that using ultrasound, reading ultrasound is pretty subjective. There is a high inter-reader and intra-reader variability. To solve this issue in this paper, we want to provide an objective liver fibrosis prediction score. An early and reliable detection enables doctors to control the progress of the disease, to prevent mild liver fibrosis to develop into cirrhosis, and finally prevent liver cancer. We insist that we want to control it early, is that this is a non-reversible state process. So if we can control it as early as possible, that's better. So as we are showing here, we want to put an early stop to the development of disease with the red line over here between fibrosis and cirrhosis with the help of our algorithm. In our paper, as shown in this algorithmic workflow figure, we have 3 key innovations. The first one is to use clinical ROI pooling to discourage the network from focusing on spurious image features. The second is global hetero-image fusion, which can do an early fusion of image features with any arbitrary number of images in the ultrasound study in both training and inference stage. Finally, we use view-specific parameterization to tailor the analysis based on the view being presented using a style-based parameter. We are the first to propose a deep global hetero-image fusion approach and the first to combine it with a view-specific parameterization. So first, let's see what's going on with the clinical ROI pooling. The reason that we want to make a difference here is that the baseline model do not perform so well. The partial AUC is only about 0.71. The idea that came to our mind is try to make use clinical domain knowledge to boost the performance of our algorithm. Based on the discussion with our doctor and literature review, we found out that the two major diagnosis criteria include: first, check whether the liver surface is smooth, and that means whether the top boundary of the liver has nodules or is continuous. Second, to check liver parenchyma to see whether it's coarse or not. These two criteria are all about segmentation. So what we do here is to use a vanilla UNet to segment the liver and draw a clinical region of interest as shown in this figure. First, we have the original image. And by using UNet, we got the segmentation mask. Because we don't want to miss any pixel of the top boundary, as we discussed, we draw a square ROI on the top half of the segmentation and shift it up with 10 pixels. By combining the two masks, we have a clinical ROI. As shown in this algorithm workflow, we multiply the clinical ROI with the feature map to get a clinical ROI pooled feature map. Experiments show that limiting the field of view with clinical ROI improves performance, which coincides with clinical domain knowledge. Then let's discuss about the global hetero-image fusion. Traditionally, in multi-instance learning, models do a late fusion. That is, for each input xi, a yi is predicted, and this is done to all of the k input images. Finally, a mean or median of all yi's is used as the final output. Our idea is that instead of to fuse results just before reporting, an early fusion may better help better help our algorithm to assemble information in the feature extraction stage. Here, global hetero-image fusion uses features early between the CNN backbone and the connected layer. As a fully connected layer, as we are showing right now, each input x image xi clinical ROI pooled feature map GI is calculated, and this is done for all k images. We calculate the global hetero-image fusion feature map by concatenating the mean, variance, and max of each pooled feature map. Here, all the features calculations are element-wise calculations. And finally, we use this fused feature map as the input of the fully connected layer and the prediction and predict the final result. So the global hetero-image fusion is between the CNN backbone and the fully connected layer. An advantage of a global hetero-image fusion is that any arbitrary number of input images can be managed. So no matter the ultrasound study includes how many images, maybe 1, maybe 2, or maybe 20, we can always provide a reliable prediction. However, we do need to notice that because we are fusing several images into one study, the scale of training set is reduced. And that's why global hetero-image fusion needs another training strategy. It needs to use different random combination of images from one study in the training stage. Now let's look at the view-specific parameterization. Because the limited scanning field clinicians always do scans from multiple views, as we discussed. And here are the 6 view groups, viewpoints in the liver ultrasound scan. In our data set, actually, we do know an additional label where this image was got. Because each view is presenting a specific angle of the liver, so we want to train a set of parameters for each view specifically. However, we cannot really do it because our data set is small, which is not enough to train a standalone ResNet for each view. Our solution over here is to customize only with the normalization layers in the ResNet backbone for each view, as shown over here. And the other single blocks share the same weights. By doing this, so first we do provide view-specific parameters for each view. And second, an additional set of parameters could be trained with very few additional parameters needed. So what if we do not know the view of our input image? As we discussed before, we trained a view classifier, and we think that could be a good solution to train a classifier first. So by combining the 3 innovations together, we have the complete pipeline for ultrasound liver assessment using deep learning. Our AUC is 0.91, which with a recall at 80% precision equals to 84%. Here we show the partial ROC curves for our algorithm. Same as discussed, we use the area with false positive rate smaller or equal than 30%, which is clinically useful. And here we show the ablation study of our algorithm. We can see that each innovation contributes to a part of this improvement of the final partial AUC. To sum up, in this paper, we put forward a principled and effective pipeline for liver fibrosis characterization from ultrasound studies with 3 innovations. The first is clinical RI pooling. The second is global hetero-image fusion. And the last one is view-specific parameterization. Experiments show that these innovations, we can boost the partial AUC for about 7% and recall at 90% precision for about 22%. And finally, we hope that this algorithm could help doctors diagnose liver fibrosis. Finally, let's conclude our discussion today. In this presentation, we discussed about 3 deep learning methods which could be helpful to clinical chronic liver disease diagnosis with conventional ultrasound images. We might forget these algorithms, but please keep in mind to take care of your liver, so you might never need the help of these algorithms. That's all topics I have for today's discussion. Thank you so much for being here. Please do not hesitate to ask if you have any question. Thank you.
Thank you, Bowen. Excellent talk. So now it's the time for questions. So for audience, if you have a question, you could either raise your hands or type your question in the chat box. Let me ask a question first. Could you help go back to the subjectivity algorithm?
No problem. Give me 1 minute. This one.
Yeah. I see that the ADDLE feature is added to. So could you go to the next slide?
Maybe I think you are asking about this slide, right?
Yes. Yeah, I saw the ADDLE feature is added to those REST blocks. Is there any reason that you use adding or not, like concatenating or other ways to aggregate?
Yes, for adding, like we actually followed one CVPR paper in 2019, and that paper discussed that whether we want to concatenate or add this learned latent space into the existing network. And with the experiments of that paper, actually adding gives a better result. And that is also a research topic that is done in the inference, causal inference study, so that there's actually a set of mathematical equations. And so theoretically, adding makes more sense. than operations like concatenating or other operations. Thank you for this question.
Thank you. Thank you. I saw a question from Q&A from Xue. Thank you for the clear and nice presentation. Is any of the data sets used in these papers publicly available?
Yes. So let me go to this slide. So we published our clinical journal paper, which is being accepted, but I think it's still in press. In this paper, we have our validation set available for all public access. So please wait like for maybe 1 or 2 months, so you can get access to this. You can have the path to this data set.
Yeah, will it be available after this paper got officially published, or any link is already there?
I think the link is already there. It's just I don't have it at hand right now. Maybe we can, if you need that, we can discuss. Give me an email. I can share the link to you. I think it's already on GitHub.
Okay. Thank you.
Yeah, thank you.
There's still the question of the subjectivity. You added the adult feature in 2 of the blocks. So
Yes.
have you done like ablation study on what's the effect of adding this raters feature of different level of the network?
Yes, actually, we did this experiments on our development data set. Actually, we did like all combinations of like whether we can insert into the first one, second one, third one, fourth one, and all combinations. So the result I'm showing over here, insert into the second and third one, is the best configuration we got during our experiments. But that's only based on our development set. So if any of you want to try this algorithm on your data set, I encourage you to try it with our combinations on the validation set and decide whether to insert it into the existing backbone.
Yeah, good. Thank you.
Yeah.
Is there any like future plan for this work?
Yes. Give me 1 minute. So one of the future work is that give me 1 minute. I cannot find the slide. So where is it? Yes. For the first journal papers, one of the future work is to run a multi-set validation, because right now we only have it tested clinically on Chang Gung Memorial Hospital, and part of it in Shanghai Ruijin's hospital. So to make it a more meaningful study, actually it needs to be tested in more hospitals. And the second work is that, as we showed in this slide, we actually, because of the latent space introduced, we want to learn that how this latent space could be more effectively used in the inference stage. So right now we used a aggregation, but actually the performance, if we do a PCA, this latent space could be further decomposed and combined meaningfully. And we want to see that how this combination with different lambda could affect our performance. And that is one of the research direction.
Thank you.
Thank you for the question.
If there's no more question, I think that would be that's it for today. And thank you for the wonderful talk. If the speaker permitted, the recorded video of the talk will be available on the YouTube, our MICCAI Industrial Talk channel. You can find the link of this channel on the MICCAI's email of the MICCAI Industrial Talk.
Thank you a lot. Have a good day.
Thank you. Bye.
Bye.